Hello, my name is Janie Lee. I'm a professor of radiology at the University of Washington in the United States of America. I'm here to present our research, Impact of Surveillance Mammography Intervals Less than 1 year on Performance Measures in Women with a Personal History of Breast Cancer, on behalf of our study team from the Breast Cancer Surveillance Consortium. This slide presents conflict of interest statements from the study team. In particular, we note that no conflicts of interest are relevant to this article. Advances in screening and treatment have reduced breast cancer mortality by 36% from a peak in the 1990s. Women treated for primary breast cancer remain at risk for second breast cancers, either recurrences in the index breast or in the contralateral breast. The goal of post-treatment imaging surveillance, as in screening, is to detect asymptomatic cancers to enable interventions to extend survival and quality of life. The mainstay of post-treatment imaging surveillance is mammography, and international guidelines are consistent in recommending mammography at annual intervals. In United States clinical practice, the American College of Radiology's Breast Imaging Reporting and Data System, also known as BI-RADS, supports regulations for all mammography facilities to analyze diagnostic performance to identify deficiencies, facilitate research, and improve outcomes. BI-RADS guidance enables standardized performance outcomes across facilities, and national benchmarks have been established for mammography, ultrasound, and MRI. Performance audits are conducted at the examination level with breast cancer status based on diagnoses which occur during a standard follow-up period after each imaging examination. BI-RADS recommends using a follow-up interval for breast cancer ascertainment that is aligned with the recommended screening interval. For surveillance mammography, that interval is 1 year. Interval cancers, or cancers that are diagnosed within 1 year of a negative mammogram, are higher in women with a personal history of breast cancer. Efforts to reduce interval cancers include performance of mammography at intervals more frequent than 1 year, or supplementing mammography with additional modalities such as MRI or ultrasound. When multiple mammograms are performed within a 1 year period, shared follow-up periods can occur. A breast cancer diagnosed during shared follow-up periods can result in multiple mammograms associated with a single breast cancer diagnosis. This artifactual inflation of the number of breast cancers detected in turn affects calculations of performance measures in an audit. The challenge of shared follow-up periods is illustrated with the following slides. A mammogram with negative results and no breast cancer diagnosis during the follow-up period is classified as true negative for auditing purposes. A mammogram with positive results and no breast cancer diagnosis during the follow-up period is classified as false positive. If a subsequent mammogram occurs during the follow-up period of the initial mammogram, there is no change in classification at the end of the 1 year follow-up period. However, the initial and next mammogram have shared follow-up periods. Applying truncated follow-up, which ends the follow-up for the initial mammogram at the time of the next mammogram, eliminates the shared follow-up periods. Because no breast cancer has been identified during the follow-up period for the initial mammogram, the true negative or false positive status remains unchanged. We now move to a scenario of breast cancer diagnosis within 1 year. A mammogram with negative results is classified as false negative for auditing purposes. A mammogram with positive results is classified as true positive. If the next surveillance mammogram occurs within the 1 year follow-up period of the initial mammogram, the breast cancer status remains unchanged, either false negative or true positive. However, the single breast cancer is additionally associated with the additional mammogram which preceded it. When truncated follow-up is applied and breast cancer status is assessed, the initial mammogram with negative results is classified now as true negative, since no breast cancer was diagnosed during its follow-up period. The initial mammogram with positive results and no breast cancer diagnosis during its follow-up period is classified as false positive. The subsequent breast cancer diagnosis is only associated with its immediately preceding mammogram, and the overcounting of breast cancers for the performance audit is eliminated. The purpose of this study was to assess the change in performance measures using a truncated interval that eliminated shared follow-up periods compared with standard one-year follow-up. To assemble the study cohort, we began with women with primary breast cancer diagnoses at 5 participating breast cancer surveillance consortium registries. We included women ages 18 years or older, AJCC 8th edition anatomic stage 0 to 3 who received definitive surgical treatment, except for bilateral mastectomy, who had at least one imaging examination greater than 6 months after diagnosis. We then applied examination level criteria to identify mammograms performed for asymptomatic surveillance as shown on the slide, in particular excluding mammograms with self-reported symptoms. We further excluded examinations to refine the dataset for performance analysis. The final dataset comprised 117,971 mammograms, either digital mammography or digital breast tomosynthesis, from 32,331 women. The pie chart demonstrates the race and ethnicity distribution of the women in our cohort, with 79% of women of white, non-Hispanic race, and 10% of Asian or Pacific Islander ethnicity. The mean age at first cancer diagnosis was 59 years, mean age at mammography was 65 years, and 39% of mammograms had dense breasts. We found that 20% of surveillance mammograms were followed by a subsequent surveillance mammogram within 1 year. When truncated follow-up was applied, the follow-up periods ranged from 3 to 9 months for the majority of exams with short interval follow-up or breast problem indication consistent with semi-annual surveillance imaging intervals. For screening indication mammograms, 59% had truncated follow-up at 9 to 12 months, consistent with early return to annual surveillance. With standard one-year follow-up, 1,597 mammograms were associated with second breast cancers. When truncated follow-up was applied, breast cancer outcomes were reclassified for 179 of the 1,597 mammograms with associated breast cancer diagnoses. Of these, 89% were changed from false negative to true negative status, and the remaining 11% were changed from true positive to false positive status. This resulted in 1,418 second breast cancers, each counted only once. Interval cancers decreased from 597 to 420, a 27% reduction. With standard follow-up, the overall cancer detection rate was 8.6 per 1,000 mammograms. The interval cancer rate was 4.9 per 1,000. Sensitivity was 63.7%, and specificity was 98.1%. With truncated follow-up, the decline in the interval cancer rate from 4.9 to 3.6 per 1,000 examinations was greater than the decline in the overall cancer detection rate. Overall sensitivity increased to 74%, specificity remained stable. Across the indication groups, the greatest decline in interval cancer rate was observed for short interval follow-up mammograms, decreasing from 9.2 per 1,000 to 3.5 with truncated follow-up. The short interval follow-up indication group also showed the greatest increase in sensitivity, from 38.6% to 60.6% with standard versus truncated follow-up, a difference of 21.9%. For surveillance mammography in United States community practice, the observed pattern of care reflected guideline concordant annual surveillance mammography for the majority of patients. For mammograms which were followed by a subsequent mammogram within 1 year, ending follow-up of the next surveillance mammogram eliminated shared follow-up periods. Each second breast cancer diagnosis was associated with a single preceding mammogram, with 89% of mammograms with reclassified breast cancer outcomes changed from false negative to true negative. Thus, applying truncated follow-up resulted in more accurate estimates of diagnostic performance, particularly of sensitivity, for comparison with national benchmarks. The main limitation of our study is the possibility of misclassified examination indications, with observed variability in diagnostic performance likely representing underlying prevalence of cancer in each indication group, relatively small sizes of second breast cancers, differential coding across facilities, or most likely a combination of these factors. This limitation is mitigated by our rigorous process of excluding mammograms associated with symptomatic presentation and supported by the observation that truncated follow-up periods corresponded with semi-annual and annual surveillance intervals. Our results apply to other settings where screening is performed at more frequent intervals than 1 year, such as multimodality screening strategies utilizing MRI or ultrasound to supplement mammography in women at increased risk of breast cancer. In the setting of multimodality screening audits, similar issues of shared follow-up periods and challenges with breast cancer outcomes ascertainment exist, where a single cancer may potentially be counted as both true positive for one modality and false negative for another. Further studies are needed to establish approaches for supporting performance assessment and benchmarking when evaluating the effectiveness of screening and surveillance strategies. We'd like to acknowledge our funding support for this study, as well as an additional study team member and the women who contributed data for this study. Thank you for your time and attention.